Good afternoon, and welcome to this IAS-USA COVID-19 conversations. This is one of several webinars that we've done in which a group of colleagues gets together and just talks about what's happening with COVID. Today, we're going to talk about sort of the latest update and hear a little bit about COVID, but also respiratory syncytial virus and influenza. With me today is Dr. Bonnie Maldonado. Bonnie's a professor of pediatrics at Stanford University and somebody who is also a member of the ACIP and an expert in the area of vaccinology. With me today is Dr. Michael Saag. Mike is a professor of medicine and infectious disease at the University of Alabama at Birmingham, and is a well-known HIV investigator. And later today, we'll get also Dr. Peter Chin Hong of the University of California, San Francisco will be joining us. Peter is running a little late, but I'm sure he'll join the discussion later on. So I want to start just talking a little bit about what's happening with the epidemiology of COVID. What are the things that we're seeing, and do we need to be concerned? You know, this morning, for example, in the Washington Post, there was an editorial from Eric Topol that says the coronavirus is speaking. It's saying it's not done with us, and he talked about how we've let our guard down and the virus has mutated, and this new dominant virus, primarily in Northeast in New York, this XBB 0.1, 0.5 is really a highly transmissible virus, and it's causing a lot of Havelock infections and some hospitalizations. So maybe we'll start with you, Mike. Tell us a little bit about what this virus is. I'm having trouble just keeping up with the names, honestly.
Yeah, it's like a alphabet soup with some numbers attached. And what I think we can take home from this, Carlos, is that the last year or so has all been Omicron variant. And we've learned about the BAs and their number system. And in fact, the more recent booster that was released in September is a BA.4/5 variant booster that's really important for all of us to get because the previous vaccine really was good against the original strain and helpful for Delta, but it really doesn't quite work as well for Omicron. But the BA.4/5 will protect against that variant to a good degree and even has extension to the XBB. So that's what I think our take-home point. Yet the uptake of the more recent booster has only been about 15% of the US population, despite its availability relatively free to everybody since September. So it's really important to get that.
Let me just add that I really agree with Michael about that, but what we're seeing over time is that people, as Eric so rightly said, the virus is not done with us, but it seems that we're done with the virus. It is there's still a lot of robust data coming out around real world effectiveness, and these vaccines are protecting us from severe disease. So remember that huge onslaught we had in 2020 was because we had no immunity. So that immunity is not long lived. And so if we don't continue to get, at least for now, boosters, we're going to continue to be at risk for disease. Maybe not as severe for some people, but we'll continue to see a lot of community transmission. And right now, our positivity rates around the country are really high. They're over 10%. That's just about as high as they've been since December and before. But we're not seeing as many hospitalized individuals. So nobody wants to be sick. And we also know that we can talk about this later, Carlos, that long COVID can be associated with these infections as well. So there's nothing to sneeze at, no pun intended.
So Bonnie and Mike, you know, I think one of the confusions around the vaccines is that these vaccines are not really very good at protecting you from infection, right? And they're okay. They have some modest protection against infection, but it's not great, maybe 30% or so. But they're really good at preventing you from getting severe disease and death and severe complications. And I think we haven't been very good at communicating this. So people say, why should I get vaccinated if I got my vaccines and I still got infected?
Yeah, that's a great point. I just wrote a piece about polio. That's my primary field that I've worked in for many years, along with HIV. And that's a perfect example. We have very few vaccine viruses that provides sterilizing immunity. So you're almost always going to have some degree of infection, even after vaccination, but you won't get sick. And I don't think we've seen that in the literature so much. I think the emphasis, rightly so, on testing for infection has really focused on people saying, look, I still got infected. But the ability to keep that infection to asymptomatic disease or to, less serious disease is critical. But as with polio, what we see with these viruses is that if you continue to get infected and your viral load is low, then you're going to be less likely to transmit. So it also supports the reduction of community transmission. I don't think we message that very well.
Welcome, Peter. So Mike, one of the questions appearing in the chat is around monoclonal antibodies. We're losing them. We lost peptidilumab. Now we're going to lose Evusheld. Do you know of anything in the pipeline to replace those monoclonals?
Yes and no. I know of I have some colleagues who have developed a broadly neutralizing antibody that appears really robust against most strains. The problem is they're having trouble finding a pharmaceutical partner to link with. And what I've heard is that the pharmaceutical companies, since, quote, the government's not paying for it directly anymore, don't have much of an appetite for developing a product that's going to potentially have a short treatment lifespan because of the variants. And so we have to really come back maybe at the level of the federal government to see how we can encourage this. What I heard was that a couple of the companies have shown the government, well, here's how you can make this stuff. You have at it. I'm thinking, well, you don't want the government necessarily to get into the pharmaceutical development business. So we should find a way to partner, but it really is a huge hit, especially as you mentioned, the loss of Evusheld for a lot of immunocompromised people is really scary. And the Paxlovid certainly can work, but some people can't take it because of the ritonavir moiety. So I'd love to see us keep developing. I don't think it's a problem developing candidate product. We can do that. It's a question of large scale production and distribution that really pharma is set up to do very well.
Yeah, there's also the active trials. And Paul and I on a DSMB for some of the active trials, and there are a couple of products out there that are not the ones we've seen now, and they are to a certain extent the NIH is underwriting some of the trials themselves. But I think the problem has been now, of course, changing courses around prevention of severe versus mild disease, and really these trials were all set up back early on when and is prevent hospitalizations and deaths. So those are still ongoing, and they're multinational trials, but they are taking a while to enroll. And traditionally, as you know, Mike, in particular, antivirals are very, very hard to come by. It's just been tough to get, any antiviral drugs or products for any disease. So we really feel like the active system has been one incentive to getting investigators and countries on board to try to do these studies.
I think it's worth.
So Peter, Peter, welcome. Welcome. I wanted to, we talked about Paxlovid, but I wanted to, if you can, mention the panoramic study and mention what your interpretation is on that study, because Paxlovid and Molnupiravir were developed primarily tested in non-vaccinated populations, but we're using them in highly vaccinated populations. And now we're beginning to see data on vaccinated populations. So how are you using these drugs, and how do you interpret the data of studies like Panoramic?
Yeah, so I think that, first of all, we aren't using enough Paxlovid, as people said. I think some estimates about 20% of those eligible above the age 65, and there are lots of barriers. But like you mentioned, Paxlovid was initially studied in RCT study in people who are primarily unvaccinated. So whether or not it's generalizable and whether or not you'd have the same bang for the buck, I think led others to look at looking at whether or not what the real world efficacy was. So like you mentioned, if it was 90% in the pure unvaccinated population, about 70% in a sort of like real world setting, it's still giving you a lot of benefit, I think, in my estimation compared to depending on who you are. But whether or not it's you're going to get the same benefit at all age groups, it's one thing, but then again, it's balanced by, looking at the possible effect of Paxlovid on long COVID. So I think some people are balancing the effects of preventing hospitalizations with that effect of preventing long COVID. So I think, based on that VA study of around 20 to 25%. So, but that's again an older population.
Yeah. Carlos, if I can interject here, that I recently had a bout of COVID, and I've been vaccinated, and I had previous COVID, but I started Paxlovid within 35 minutes of my positive test, and my symptoms lasted 24 hours and they were gone. And then I tested negative after 2 days of Paxlovid. Now that's anecdotal, but I think the trick is getting people on treatment early. And I don't think I was at high risk, even though I'm older, of being hospitalized, but I had zero lower respiratory symptoms that developed. And again, getting through the illness phase was 180 degrees different than my first experience in March of 2020.
Yeah, that's a really important point. I was gonna ask you, Mike. So somebody put in the chat, let's suppose that you had not been boosted and you got COVID. When would you recommend the person gets the vaccine?
Generally speaking, first of all, I'll say it's not 100% known, but I think based on the biology, I would say within 4 to 6 weeks. Bonnie, I don't know, you're the vaccine expert, but that's what I would deduce from what I've read.
Yeah, generally, we know that from the original wave, that people can get reinfected within 30 days. And CDC generally recommends waiting at least 30 days, but between 30 and 60 days is a good time, if you want to prevent disease. I think it's a really great idea. Yeah.
Because
so
I've been recommending people wait a little longer. There's some data from the lab, I think from Tony Fauci's lab, suggesting that you get a better response if you wait 10 to 12 weeks. So I've been telling people to wait a little longer.
Depends on the prevalence, right? So you want to wait long enough to get you don't want to wait too long and get infected. So it depends on the dynamics of the viral transmission at the time. But yeah, absolutely. The longer you wait, the better you are in getting. So within 3 months, for example, you get a really good response, although you still get a pretty good response after 30 days.
So so how about remdesivir? Are we using remdesivir at all anymore, primarily in the outpatient setting?
I think
We're still using remdesivir, but more. We're not seeing a lot of inpatients at this point, and those who we're seeing are generally asymptomatic. But we still have that as a backup, especially because we're losing all of our other options with all the other monoclonals being gone. Remdesivir is a good backup, but it's certainly not at the same level as we were using it even 6 months ago.
I think in the immunocompromised population with a lot of potential drug interactions, Paxlovid, I've seen remdesivir use sort of increase, and a kind of setting would be, okay, the immune compromised individual gets admitted. They don't have a lot of symptomatic disease yet, but they're COVID positive. People are worried that they may get very ill fast enough. They get admitted, they don't look as bad. They get started on remdesivir, and then they convert it to a 3-day period for early disease. So, kind of nice for drug interactions perspective. And also you have like a 7-day window period from the trials versus 5 days for Paxlovid. So that's another kind of like if you're in between day 5 and 7, remdesivir might be a cop out where you might still get benefit.
Right. We've kind of danced around this, but I think it's worth saying explicitly that there really is no available monoclonal antibody for these current Omicron variants. That needs to be clear. So what we've done is we've converted our monoclonal antibody facility, if you will, to giving daily remdesivir for 3 days to the people at high risk, like the immunocompromised patients who we used to give monoclonal antibody to and they got sick. And my personal thought is if you've got an antiviral, use it early, like as early as possible, because that way you can nip it in the bud. And rather than waiting for symptoms to get so bad that they have to go in the hospital, I think that's a reasonable approach. But what we need is an oral version of remdesivir.
So a good question that appears here is, what's the benefit of Paxlovid in non-high risk individuals? I mean, I'm thinking about, an otherwise healthy, I talked to somebody today, otherwise healthy, 45-year-old individual who's an athlete who got COVID. And my recommendation is that there's no reason to treat this individual. There's no point, there's no benefit. Now, this person is saying, does treatment prevent long COVID? And I would say the answer to that, we don't know, right?
We don't know.
It
I
will
mean,
show-
Bonnie at Stanford, they're doing that RCT, right? I mean, they're doing RCTs. other
Yeah,
places.
so we're part of the Recover trials, and I think UCSF is as well. And we started we were one of the sites that was doing the Paxlovid study for the prevention of to study for the prevention or mitigation of long COVID. But, these things are going to take a while.
Yeah, but that's not treating people during the acute event.
No,
That's treating
right.
people with long COVID. That's a different story.
Mhm.
And it's 15 days of Paxlovid for those individuals.
Yeah.
So another question, my friend David Resnick says, how can regular people get access to Paxlovid within a few hours of positive test? Well, David, number one, you're not a regular person. You have access to a lot of physicians who can call your prescription immediately. And quite frankly, I find it very easy. You say you're positive, you call the drugstore, you get the drug. Right now, there's actually more Paxlovid availability. There's more supply than demand in our country. And it's a little frustrating. I was reading in Nature this morning, there was an article in Nature this morning saying that it's actually less than 20% of cases are getting Paxlovid, Peter, of people that actually should be on drug. So we're really not using it. And the UK is even less. The UK is less than 5%. So we got to be doing better with that.
Well, one of the issues, of course, and this will continue to be a problem, is the federal dollars to really support a lot of the dissemination of information really dried up and was really not even available for things like Paxlovid. So we ran into that locally and nationally. We were trying to support education, and there's just no way that the federal government can provide funds to, do even public service announcements. So it's been hard to embed the message of Paxlovid use to the general public or even to physicians. I walked in last Christmas during Delta, so it was really even more infuriating. I walked into my pharmacy locally, and the pharmacist was on the phone telling the patient, "Oh, the doctors keep prescribing this Paxlovid, but I don't think you should take it." I was furious. First of all, going against the medical advice, and secondly, really belittling the use of Paxlovid. This was during the interval between Delta and Omicron, so it's really shows you. And we're in an area where I think this information generally doesn't happen. So I brought it up, and the person was really recalcitrant. So I feel like this is again anecdotal, but I think these are the kinds of things that we are facing, assuming the will even try to prescribe it.
So can we talk about Paxlovid rebound? Somebody writes in the chat, says, we're seeing a lot of symptomatic rebound with Paxlovid, and this is making us less eager to give it.
It happens. I don't know that there's a firm epidemiologic number, but what I've been reading is about 15%. I think a lot of it depends on when it was administered. If it was given very early, perhaps there's more of a likelihood. I don't know, but it's not a reason not to give the medicine. You get huge benefit, and the rebound, while it is happening, and yes, people get some symptoms. Number one, to my knowledge, there's not been a single hospitalization from Paxlovid rebound that's ever been reported. And so it's usually a mild relapse, and it only lasts about a couple days. And yes, the test can convert back to positive. Nobody knows whether that means it's transmissible again. Probably is. I think I'd isolate the person while they're having their symptoms, but that's certainly not a reason not to give the medicine.
Now, let me ask you, what are you doing with your rebounds? Are you treating them like Tony did? You treat them again?
I have not.
Neither am I. Okay.
I mean, I don't know how long, and
Yeah, we don't have an indication.
I don't have a clue of what to call it if they rebound a second time, a rebound.
Well,
Now,
and then, of
let's
course,
be real clear that I don't.
Some of the data around longer-term follow-up of individuals on and off of Paxlovid, you're still going to see rebound in the patients who didn't get Paxlovid at all. So it's not clear that this is part of the natural history of the virus either.
That's
why I don't
calling it COVID rebound, not Paxlovid rebound.
I'm
I don't
sorry,
like to call it
COVID
Paxlovid
rebound. Sorry.
So how about going longer with therapy, Peter?
I mean, I think Yeah, I think I probably want to wait a little while. I know that people have done it. Actually, I know of colleagues who've done it informally. They're a little bit worried, they're immune compromised, their symptoms were continuing, but it's not something I would normally do. Unlike, I agree with Mike, I haven't seen a single person who got rebound where they've gotten worse symptoms, and actually it's just like mild and it went away eventually. And the second thing I would say is that with rebound, there are people who continue to check their virus, and I would definitely not check anything unless you definitely had worsened symptoms after you got better, because like in the case of President Biden and Jill Biden, nothing was happening and people were just checking them over and over again.
Yeah. So Carlos, I think it might be worth all of us just hitting the pause button and pulling back to the big picture. Imagine the world if we didn't have an antiviral to give. I mean, we'd all be clamoring for one. So we actually have one, right?
You're talking about most of the world, Mike, and I think we also need to emphasize that.
Right, and so we do have something. We should try to use it and understand that there's limitations. The second point is that those of us who lived through the very early days of AIDS, we had AZT available. We really weren't sure how to use it properly for several years after. Remember, we were giving 200 to 300 milligrams every 4 hours and people waking up. So we still have a lot more to learn about the best use of Paxlovid over a longer period, and hopefully newer drugs will come along that will take its place without the ritonavir.
So question that's coming up, people are saying, well, I got my bivalent booster back in September. When do I get my next vaccine? Because the question is a little deeper, is what's the durability of the vaccine, right?
Oops, we lost Vonnie. She's probably the best person to answer that too. I'll start, but I think the answer obviously is not known. And we're going to have to follow the population of people out to see how long the immunity lasts. Hopefully we can get to an annual renewal of this, and it's us versus the virus. And as Eric Topol said, this virus is constantly mutating and it's coming back. So I don't know. So Vonnie, you're back. We're hoping that you could answer the duration of the new booster.
Yeah, so we don't really have a good information. The CDC's been trying to track back real world effectiveness, and it looks like the durability really depends on the wave and how many, and how old you are as well. But it seems like a good 3 to 6 month period is when you seem to get the best response. So I'm going to go back to what Kathy Newsel said many years ago. I love her quote that she used. We were talking about rotavirus vaccines, and they worked incredibly well in the US, but they didn't work so well in the developing settings. And somebody asked her, well, what is it, the glass half full or glass half empty situation? And she said, I don't look at it that way. I look and see how big the glass is. So, I look at the malaria vaccine, 39% effective. And I think, again, as you said, Mike, let's step back for a bit. 39% isn't 100%, but it's not zero either. The entire world is 39% is pretty darn good. So I would say if you have a 3 to 6 month window where you can be protected, I would go for that. And then the question is, when are we going to get our boosters? So this coming year, I know the FDA has a meeting coming up at the end of this month where they're going to talk about their strategy with the VRBPAC advisory group. So the question will be then, should we continue down this path? At this point, I would say we have to. We don't have a seasonality established yet for this virus. We know that vaccinated and boosted people absolutely do better than unvaccinated people or people who haven't had a booster. It's just the data continues to show that. And while people who are vaccinated and boosted can get infected, the risk is at least 2 to 10 times lower for them. So, and that's just a section. Now, if you look at other more severe outcomes, again, you have to take into account risk stratification, but it's still a pretty good deal to get vaccinated. And the question will be, if we convince the other 85% of people out there to get the booster, then we'll have to wait until the fall probably to see what the next variant is. And that's going to be a real challenge because we have no idea what's going to be around. Around variants, we talked about that earlier. I think one of the good things here is that we haven't digressed too much from Omicron. It's still basically the Omicron virus. It's a little more able to, it binds better, it's more transmissible than the original Omicron, but we don't see a new completely antigenic shift like we did with Omicron from Delta. And I'm hoping that we can keep that in mind. But the other problem, of course, is I'll get off my soapbox then, is who's going to pay for all of these new vaccines? Because this year we're going to have to we're going to see more charges, not for the vaccine, but for administrative charges. And as a pediatrician, I can tell you that administrative charges really are what sinks most practices in being able to offer even general vaccinations for children. So the financing and all of that needs to be kept in mind, especially during this year when we're not going to have an easy time sailing anything through Congress.
Yeah, but Mike, let's move on to flu. What are you seeing in flu?
It's steady. It's coming down some. It's still there, but it's not at the peak levels that we had seen like in the early part of December. It's still around. We're not seeing as many hospitalizations as we had feared. It's still lurking, of course, so we need to keep an eye on it. But that's what I'm seeing in the national data, and it's reality tested here in at least my neck of the woods. I don't know what you guys are saying.
Yeah, we're also seeing the same thing. So my question to you, Peter, is, we were concerned about a tridemic, but is that happening? And there's a lot of argument around what people call viral interference. Can you fill us in what viral interference is?
Yeah, so I mean, there's this whole issue about the idea that once a virus sets up shop, that it repels the other virus because there's only room on the bus for one. Whether or not, I mean, there's so many other confounding factors as to why we didn't get multiple or 3 viruses in the past few seasons compared to this year, that I didn't necessarily subscribe to it fully. I mean, I think it's really intriguing, but I would worry about influenza. It's always a dark horse, because if you look at last year, for example, even when we didn't have a high season, the tail was really long into early summer. And in other countries, like in South America, I think they had a second surge of influenza. So influenza is always something I'm worried about in the background. I am happy that RSV, and I'll wait for Bonnie to sanction this, is definitely sort of winding down, and there is not a lot of serious disease with reinfection RSV. So that's kind of what I think about with flu and this idea of viral interference, although it is an intriguing idea that but I think what I've seen in people before is not a lot of people getting infected at the same time, but they get sequentially infected. So I knew this person who got COVID first, and then they got RSV, and then they got influenza. So it's like one after the other, but not at the same time.
Absolutely.
Yeah, so Carlos, sorry, is my audio better? Sorry about that. They just reorganized my office here, so.
Yes, a little bit.
Okay, so there is a paper from, 2018 or 2017. This was a Princeton viral epidemiologist who did some work looking at very large data sets around respiratory viruses across the entire US population with claims data. And they did see, what they found was that certain viruses tended to appear or disappear immediately before or after others. So they implicated that there might be some impact of one virus on another, but there's no direct evidence. I do think that there could be something there, but again, it's not something that we know about for sure. What we have seen with flu, for example, this year compared to other years, is that it started about 8 weeks early. So I think it's going to end a little early, but it's not going to go away, I don't think, all the way through. We tend to see flu last until March or so across the country. So hopefully the numbers are coming down a bit, but they're certainly not down at the, down to a baseline. And what we saw after the 2009 H1N1 flu pandemic was that the season started in April that year. So it's very strange. They have the 2008 season, it ended, and then the 2009 really didn't happen. It peaked out at around April, came down in September, and there was no season in 2009 to 10. And then slowly it started to ramp up again. So I was waiting to see what might happen with COVID, but as I said before, we said before, we don't have any seasonality yet to predict with COVID, but with flu, it does tend to rebound pretty quickly. Now, of course, the whole world did mask after the influenza pandemic. So I think that shows you how transmissible COVID is relative to flu and RSV and the others, because I think we were safe against those because a lot of the mitigation worked against less transmissible viruses. So this year, I think we're going to start to see normal, whatever normal means, we're going to start to see regular patterns come back. And this year, of course, is primarily an H3 and 2 year, so tends to be a little more severe.
So how about this concept of immunity then?
Yeah, I don't really understand that term very well. I think we, despite, with all of our AI information, we should be able to figure this out. That has been the biggest question plaguing academic influenza researchers for a long time. We have so much data on serologic responses by age cohort, et cetera. It's pretty clear by now that people who have been exposed to a particular isolate, so an H1 and N1, for example, tend to do better with subsequent mutations that happen over the course of time. And age groups that have never seen a particular isolate tend to do worse. So the question then is, if you haven't seen it every year, but you had exposure, say 3 or 4 years ago, how much in debt are you compared to somebody who's never seen that virus? And I would say that there's probably going to be a differential. That is, people who've been exposed before to this particular serotype or something like it are going to be doing better than, say, others who never got infected. So it would be really nice to be able to build algorithms to understand that better, but we just haven't gotten the AI ability to really predict our pandemics any better than we are now. We should be able to do a better job.
But some people use the term immunity debt to say that your immune system isn't working quite as well right now because of the masking. So I think, it's important to know what people mean when they use that term, because it's all over the place and it's being used by a lot of people to say why masking and all the precautions we did were wrong. So, it all depends on the use of the term. It can be weaponized. That's
a really great idea. I hadn't even thought about that, actually. So here's the issue, too. We went through this with varicella zoster vaccines. So when we first started vaccinating children against chickenpox in 1995, the rates of wild type chickenpox went down dramatically. And then about 7 or 8 years later, we started to see small outbreaks again. And this was a question that Ann Arvin and I discussed. Ann Arvin was here at Stanford, and was one of the people who was very involved with developing the Merck vaccine, varicella vaccine. And I asked, we discussed this issue around, if your T cells aren't primed by continued viral circulation, what happens to your immunity? And what we saw was, after about 7 or 8 years, there was evidence that children were starting to have low-level outbreaks, but the disease was less severe. There were less lesions. They weren't as sick. But then they developed started giving kids a second dose of varicella vaccine. And to date, that's been, over 20 years now, almost 20 years now, we haven't seen a second wave. So it appears that you do need to have T cell boosts. By the way, that's another theory around monkeypox, which I don't think we're going to talk about today. But I heard this theory from our work with the White House task force, that people are suggesting that the discontinuation of smallpox vaccine in 1977 may have led to cohorts of individuals who didn't have sustained immunity against orthopox viruses. So with reduced immunity over time, you still have some immunity. We've seen that, but maybe not enough to really prevent circulation of those other orthopox viruses like monkeypox. And perhaps that is leading to cross-viral circulation at low levels, but then leading to the ability of, these super spreader events to happen. So the bottom line is we really don't, one of the fascinating things about viruses and immunity is we don't understand them well enough to think, we don't have the way to eradicate these diseases. And as long as we don't eradicate them, they are very tricky about figuring ways to come back. And our T cells very clearly do need boosts for certain viruses. Maybe all of them, I don't know. Mike, maybe you know.
So Peter, can you help us put, a lot of people have fear of getting a COVID vaccine nowadays because they're concerned about cardiac complications. Can you help us? What are you telling patients? How do you communicate about cardiac risk of vaccination?
Well, I would say, first of all, that in the vaccine, first of all, the big 30,000-foot view is you get much more cardiac risk by getting COVID than the vaccine. And then amongst the vaccine, cardiac risk tracks with testosterone and late adolescence, early adulthood in males primarily. They haven't had a lot of serious disease, and they tend to generally get better pretty soon, and more at the second dose rather than subsequent doses. So that's basically kind of the bottom line with cardiac complications. And so I started from there, and we talk about I ask people what their concerns are, and we go back and forth. But those are some of my talking points.
So another talking point is, I think, around dispelling what people see on TikTok and other places, where it's just completely off base. Every single person who, died in the last year, you immediately started to see trends of, oh, the person died from the vaccine, and to the point where publicists are actually saying they didn't die from the vaccine. So, I think we need to do, and I think we need to do, again, around communication and messaging. We just need to message better. There's been a horrible narrative around the NFL, which I just think is so exploitative and horrible, to take advantage of somebody's terrible experience to blame things like this on the vaccines. And some of the things that are being said are just awful. And I think we can do a really good job maybe of, when we talk to people, the first thing you say, here's what we know, and here's what are you hearing? Because I think what Peter does, is just reassuring people and making them understand that, even though there's a risk, what's being put out in media is completely irresponsible and untrue.
Yeah, I was going to bring that up. I mean, this Damar Hamlin story is a tragedy. It's a 1 in 5 million chance of getting that hit right at the time of the depolarization that caused the cardiac event. But it's amazing, just immediately the social media went, oh, that's a COVID vaccine. When they don't even know if he had a COVID vaccine. They're already jumping on it. I don't know if he did or he didn't, but it's out of control, the misinformation.
I think
do you remember that? Oh, sorry, do you remember that journalist who was covering the World Cup and he died?
Grant Wall.
I heard from some of colleagues who work with his wife, who's a physician, who said that she's getting harassed by anti-vaccine groups because of, I don't know what, because what did she do? Maybe because she allowed him to get vaccinated, but to add insult to injury, somebody's lost their closest loved one, and now they're being harassed. So I think we need to address this issue in other ways. It's not just about COVID, it's about all vaccines now and other therapeutics. We have parents who aren't allowing their children to get vitamin K injections at birth, and that's a good way to, allow your child to have a horrible bleeding diathesis. So the public health, the trust in public health and science has just really taken a hit in the last 3 years. Sorry, Peter, go ahead.
Oh, no, I was just going to bring up the Grant Wall and Celine Gruder, op-ed she wrote in the New York Times too. And people were so mean to her, and she wrote about this and said it was karma because she was so pro-vaccine, and and he had died of an aortic aneurysm, that it was a complication of the vaccine. And that was really, again, adding insult to injury, as you said. And I think all infectious disease docs and people in the field really breathed a sigh of collective relief when she had, she went through that methodical process of getting an autopsy in New York just because of all this online hate she was getting.
So let's talk a little bit about China. What do you see happening in China? What do you know?
Well,
it's hard to know, but go ahead. There's a lot of derivative data, but we don't have any direct data. Go ahead, Mike. Sorry.
yeah, I'm just saying they went 180 degrees. So for many months, they had like a zero tolerance program, which did keep the epidemic under control, right? They didn't have many cases, and then they went right wide open, and now there's a projected, I heard today that they're going to have a projected 800 million cases. That's like a number I can't even comprehend. But they're allowing flights in and out, and the U.S. is requiring testing of people flying back from China to the U.S. That's all well and good. They're going to struggle for a while. Their hospitals are stretched, and I'm just surprised that they didn't have a massive vaccine program that was implemented prior to their change in policy. It's hard to understand, at least to me.
Yeah, so I think the reasons, as you all probably know this, going from the zero COVID to flinging open the doors, I think was in response to political instability, and the government is very careful about that. But as you said, and as happened in Hong Kong, you want to be ready with vaccination. And so there were a couple of thoughts, because we don't really know the data very well for China, but it appears that not enough vaccination happened. They did do a very good job, apparently, of vaccinating older individuals. So they did have good uptake in older people, but they don't use outside vaccines. So we don't really know the efficacy or effectiveness of the Chinese vaccines at this point. And they're not letting anybody have access to outside vaccines. So there's a lot of information that we don't understand, but what I worry about is people are going to use that as an example of why should we do anything in the US, for example. But we have vaccinated people here, and we're seeing that we are able to tamp down the resurgence or the lowered immunity over time after vaccines and boosters, because we're not seeing this huge surge of deaths or hospitalizations. We're seeing more infections, but not the type of dramatic disease that China is seeing. So I think that speaks to the ability of a country to put together a full program. Now, the other last thing is CDC is recommending that rather than doing testing of people, because you can miss a lot of people as they get on planes or off planes, is to do sewage testing of planes. Now, how you would implement that, I think you could do it on a pretty quick basis. We do a San Francisco Bay Area wide testing here at Stanford of sewage, and it's a pretty real-time way to look and see. So you could take a sewage from the plane and then, for example, be able to see if that plane has individuals. Now, it could wind up holding people up if there's, if you tested people and they were all negative and then you found a positive sewage test, then you'd have to go back and retest people on the plane. But the just testing people before they come into the country is not going to stop the virus from circulating.
Yeah, we learned that a long time ago, right?
I saw some data showing that 95% of planes, when they did a small sample, were positive for COVID in wastewater. So it's like focusing on China probably wouldn't do much for preventing COVID from coming in, although one of the arguments is bad sort of variant type things.
It was actually 98%. Were 28 of 29 planes
that
had their wastewater tested recently in the U.S. on domestic flights were positive for COVID. So I'd still wear my mask on the plane. So
yeah,
not a bad idea.
One other interesting thing about the China situation is that people may know this, but they recently had emergency use authorization for nasal vaccine that's meant to be an adjunctive vaccine. It was from collaborate. I think there are a couple out there, but the main one is this collaboration between University of Hong Kong and like CanSino or something. And it looked really good in the studies, like above 80% in terms of hospitalization, I believe. But many people are looking at that, and I think there are 100 compounds around the world where could you use that as an adjunct if you really want to prevent disruption by superinfection. So whether or not they're going to deploy that or not. But regardless, all the reports that people are reading about crematoriums, and they let in all these AP reporters who went around these hospitals and saw lots of crowded situations.
So Bonnie, kids are going back to school. What are you telling parents? What are you saying?
Yeah, well, we're trying to get people to remember that every respiratory virus season it can be a risk no matter what. And we're used to this in pediatrics. So we've already taught our kids. In fact, our kids teach us about respiratory etiquette. I remember when my kids were growing up, they came home and taught us how to cough into our sleeves. So, and how to, so that's something that we need to continue to do. I think it's too late to try to build mask mandates back into the conventional wisdom. People are done with that. And maybe at this point, what Mike said at the very beginning around poor uptake of vaccines and boosters is really where we need to go back. And we just can't get people to think about it that way. We have seen a good reasonably good uptake this year of flu vaccines among adults and even children, although the rates in children have dropped off a bit since last year. So we need to keep that messaging going that vaccines are still helpful. Now, for all the other diseases that for which you don't have vaccines, we're just going to have to make sure that people stay home when they're sick, that everybody that goes to school, especially teachers and staff, are vaccinated against flu and COVID. And if children can be, they should be vaccinated as well. But I think the masking is going to be tough. The other easy thing that I think always comes up at these discussions is ventilation. I think, Carlos, you're the one who talks about this most, but ventilation, I think, is really important. And I think most of the schools hopefully have gotten to that point. And then we can talk about RSV if we have time later, but there's a lot of really exciting developments in the RSV world that I think could really put a big dent in our hospitalizations of children. RSV is the second most common hospitalization of kids under 5. And actually, there are more hospitalizations from RSV in adults over 60 than there are in kids. So still a huge, over 100,000 people are hospitalized every year, over 60 from RSV. So we have a lot. This year, I'm hoping there might be a vaccine for pregnant women, a vaccine for the elderly. And I guess I count myself in that group, although I'm not going to tell you how old I am. But there also is a long-acting monoclonal that just got filed for a BLA through nirsevimab for FDA approval. So we could see major reductions in morbidity and mortality in the coming year.
Yeah, no, RSV has some really interesting things happening. So, so what are you doing in your personal life?
Well, I've been traveling a lot. I went to the Sun Bowl. We were on planes and trains and automobiles, and I wore my mask on the flight. I washed my hands. I didn't sterilize the environment as I used to, but we did fine. I tested when I was going to go to meet with a lot of other people in close quarters. And then to the extent possible, I don't wear my mask, for example, if I'm going to go like to Home Depot to get sandbags so that our house doesn't flood this week with all the rain, because it's a big open air area and I'm not going to be sitting close to anybody. But if I'm in a close environment, I've been wearing my mask, at least, in some of these closer conferences. I went to a global health conference in Miami and everybody was masked for the whole meeting. This was just a month ago. But I think as things open up a bit more, and I was more worried about flu.
What kind of mask are you using when you go?
I mean, a surgical mask is fine. I do use N95s, but a surgical mask actually isn't so bad either. It depends on where you're going to be. I mean, at the hospital here, we're still just using the N95, the regular surgical masks, unless you're seeing, if you're in clinic or you're in a hospital room, many of us will still wear the N95s. But if just walking around in surgical is fine. I don't know what the others are doing. Mike and Peter, what you guys are doing.
Well, I think we're going to be living with this for a long time, unfortunately. As Eric Topol said, this virus isn't done with us. And so we're going to we should get on with our lives, but monitor the situation. When there's a spike, like we're kind of going through now, or at least an increase after the holidays, go back to masking. Masking works. And there's a recent study of surgical masks versus N95 that on the surface showed absolutely no difference. But the problem is Paul Saxton had a wonderful blog, very well reasoned and really great logic that basically showed that despite the fact that the randomized trial showed no difference, there were very few transmissions within the hospital setting, that most of the pickup of these cases was in the community. And so if people aren't wearing their masks in the community, then you can do whatever you want to in the hospital. But you're going to be living in a world where COVID is there. I think one of the participants just said, I'm masking a lot and I haven't had COVID. Yes, that's correct. And I think we should be masking more as these outbreaks happen. You can relax maybe a little bit when the numbers come down, but that's what I've been masking in crowded areas like you were saying, Bonnie.
Now, how about recently Shay came out with a statement that, that I support, that there's no need to do asymptomatic testing in hospitals. What are your hospitals doing?
Yeah,
we
we
stopped testing asymptomatic individuals at UCSF.
So we there was I think we started asymptomatic testing actually way back because of pressure from healthcare providers primarily. I think they were really worried, especially those that were generating aerosol procedures, et cetera. And because of the safety issue, and we didn't really understand, we did institute it. Then what happened is, because we have two separate hospitals, a children's hospital and an adult, we had to harmonize because the services were coming from one hospital to another, and nothing undermines faith than seeing the hospitals have two different policies. So we really aligned and decided to do testing of everybody. But it's really hard to peel that back without scaring people, although at this point we've really been able to engage our workers. But we would have done it 6 months earlier, but it just took us a while to educate the healthcare personnel. That was really the group that was most worried, I think. I don't know what you all thought.
One of the audience members just said that they were shocked at taking their mom to a cancer center that had relaxed their mask mandate. I think we still should be wearing masks in the hospital.
Yeah,
all the healthcare workers.
Yeah, no question.
That's just a no-brainer right now.
Yeah, no question.
It's interesting. For many years, we would wear masks during influenza season when we went into the leukemia wards, right? Because of the risk of influenza.
Mhm.
I think after COVID, it's a little bit like how we went to universal precautions for HIV. We, you and I, Mike, when we drew blood as interns, didn't have to we didn't wear gloves. And then, all of a sudden, universal precautions appeared and we started wearing gloves. And that's now part of the standard, right? So I think masking will become part of the standard of evaluating a patient.
Honestly, that was what I always hoped for when I was before COVID. I thought, I wish we could mask everybody when they come in, because people want to see their family members. They're not going to tell you. And they also tend to underplay. Well, it's just a scratch in the back of my throat. But if we ever saw nosocomial transmissions of, say, flu or RSV or something else, you could almost always, I would say 90% of the time plus, you would find the source. So, and those are people who were just, either early on, just feeling early symptoms and then got sick the next day. And I think masking would be I do think that masking is so much more important than asymptomatic testing. It is going to be the way we're going to keep people healthy. Remember, at the beginning of the pandemic, that's how we tracked how well we were doing. And I know that, like with all of you here, we just did not see transmissions happening in the hospital, despite everything we were doing, because we were masking. And, some people, even with N95s, with surgicals, we're doing just as well, as long as they weren't doing aerosol generating procedures. So I think it's a good way to go.
So a couple minutes left. It's always hard to look at the future, but what do you see in the next 3 to 6 months, Mike? I think you need to unmute, Mike.
I'm sorry, I missed the question. I was scrolling through the Q&A. What was the question?
So the question is, it's hard to look into the future, but what do you see in the next 3 to 6 months?
Yeah, I think more of the same. I think the variants will continue to emerge. I think we will probably have a lull now that the holidays have passed. People got together without masks. It's going to be predictable every year. But I think we'll have a decent spring. I'm just hopeful that people at risk will get their vaccinations, and that number will pick up from 15% to 40 or 50% of uptake. But I think we're going to be living with this for a while, and it's a new normal.
Peter?
I think that COVID will continue a little bit, but not at the levels of the last 2 years, kind of hovering around maybe 400 to 500 deaths a year, which is still way too much, given Paxlovid and all that stuff. I think influenza will have a slow burn. We may have a long tail of influenza. But I think I agree with Mike that we will have probably a decent spring, early summer, probably several months where things will be a little bit quiet, hopefully.
How about you, Bonnie?
Yeah, I agree. I think I'm just crossing my fingers that we don't see another weird Omicron-like shift happen, because that would throw everything into disruption. And I'm worried that China could do that. We'll see. At this point, we're just still seeing Omicrons coming out, which we can work with. But I do think we're going to see this slow, low burn that we're seeing now. We really haven't lost cases or deaths at this point. They're in a very high risk groups. And I agree that it would be nice to be optimistic about vaccines. Unfortunately, I see the opposite happening. We've had measles outbreaks. We've had a polio case. I think, if anything, I'm worried more about people's uptake of other things. So they're just so burned out. But let's just hope for a nice spring and summer where people can relax again, because we're getting back into the real, back into a new, as you said, a new normal.
So what do you think are the odds that we will see the emergence of a more lethal strain of COVID?
I don't think it'll happen now. I think it could happen down the line. I mean, coronaviruses keep doing this to us every few years. We don't really know where that Omicron came from. So I'm hoping that we won't see something like that happen. That was such an anomaly. It's hard to know whether that would happen again. I would almost call it a black swan event, but then I think I'm dooming us to having another one happen. But that was a very unusual situation. It's so distinct from the other viruses. I just don't see it happening. But again, we're waiting with bated breath to see. And I think the other thing is surveillance is going to be critical. It's by the way, the Australia outbreak really helped us predict exactly what was going to happen this year. Exactly. So we just need to keep doing surveillance, and we cannot let go of that. It's the only way we're going to be able to know what might be coming.
But I think we also need to do a much better job vaccinating those that are over the age of 60, over the age of 65. I think our booster.
Yes.
There was a very interesting paper in JAMA, I think JAMA Health Policy or JAMA Internal Medicine, I can't remember, this past week, in which they saw that in nursing homes, if you didn't vaccinate the staff, you didn't protect the employees. So again, it talks about the importance of also vaccinating the staff in those high-risk facilities, right?
So tying this together a little bit real quickly, Carlos, that, it's hard to predict the future for sure, but I think have a consensus here about hopefully it's going to get a little lower and maybe not turn more virulent. But I know pretty confidently that we're going to see an investigation out of Congress, the House, to see where the virus came from. There's going to be an origin of COVID, SARS-CoV-2. I think the leadership is going to be pushing for that.
Yeah, and I would say, Mike, as I don't necessarily agree with that, but at the same time, I would say that I'm really frustrated with the lack of transparency of China. Even right now, the transparency of China it's hurting everybody. And I think the only way to really fight a pandemic is with greater transparency. So one of the things that I've said, and I'll say it over again, is that more than testing passengers before they get on planes, we need more transparency and we need greater diplomacy, because scientific diplomacy is clearly important in trying to prevent more outbreaks.
Couldn't agree more.
That's right.
Well said, Carlos.
Well, thanks everybody, and I really appreciate the audience, and I appreciate our participants. You can to view upcoming or on demand. This webinars are posted. Somebody said, are they posted? Somebody on Twitter, please post them. Yeah, they are posted. And if you're interested in viewing them, you can go to the IAS-USA.org website and find them there. Thank you very much for your presence.
Thank you all.
Yeah, I think that went well. Thank you.
I think
Thank
so.
you.
Lots of great comments. Lots
Bonnie,
of
good to see you again. Yeah.
Yeah, you too. I hope everyone had a good holiday.
Yeah.
Thanks, Mike.
Okay, DJ. Thank you, Jose. Well done. I don't know. I forgot to bring my microphone down here, so that may have been a problem with the echo. I'll try to
No,
remember that.
I think you were okay.
Okay.
All right.
Bye-bye.
Bye. Thanks, Jose.